be discussing your intracranial aneurysm. So class, when I say aneurysm, this would involve dilation of the walls or of the cerebral artery that develops as a result of a weakness in the arterial wall. So again, the problem in your aneurysm is that there is weakness in the arterial wall. Now, what are the different causes of your arterial wall weakness? One could be your atherosclerosis. So when I say atherosclerosis, deposit of fats and plaques on your arterial walls. Next, congenital defect. Okay, class, the common site for congenital defect for your AVM is your circle of Willis. Okay, notice, class, the structure of the circle of Willis. The different pressures coming from the different arteries would cause an outpouching from the arteries. Then trauma to the head, aging process, class, could also cause arterial wall weakness. And then your hypertension, which would be an increase on the blood pressure. Okay, the continuous increase on the blood pressure, class, would result to arterial wall weakness also. Now, there are several types of aneurysm. So class, if you would look at the form of the aneurysm, okay, you have your fusiform, you have your berry, okay, you also have your saccular. And then class, you have your dissecting aneurysm. So class, when I talk about dissecting aneurysm, these are aneurysms that are about to rupture. Okay, so class, look at the structures of these different kinds of aneurysm. Now, class, when I say cerebral aneurysm, of course, it is a dilatation of a certain part of your cerebral arteries. Okay, so class, if you would notice, this illustrates your cerebral aneurysm. And then class, this illustrates your berry aneurysm, which is occurring, okay, on your circle of Willis. Look at this, that is already your anterior communicating artery. Okay, so class, the occurrence of your aneurysm in your anterior communicating artery would also remind us that the circle of Willis is a common site for your aneurysm. So what is the pathophysiology and manifestations of a patient with aneurysm? Okay, class, your aneurysm would not be a problem unless the aneurysm would rupture. Okay, so class, once intracranial aneurysm, okay, it would typically rupture, class, from the dome rather than the base. Okay, so we're looking at the rupture from that curved part, class. So this would force blood into the subarachnoid space at the base of the brain. Okay, subarachnoid will be the target deposition of the blood. Now, it would form a clot that would irritate the brain tissue. Then later on, class, inflammatory response would be occurring. Okay, and this inflammatory response, okay, would have result to your cerebral edema. Because you have cerebral edema, you're already considering the increase of the intracranial pressure and meningeal irritation. Okay, so class, basically your problem here is a subarachnoid hematoma leading from, your aneurysm. Now, so class, if I would look at aneurysm, okay, the clinical manifestations are patient would be asymptomatic until there will be rupture. Okay, there are prodromal symptoms, class, before the rupture. The prodromal symptoms could even include headache. Okay, it could include eye pain, virtual deficits, and then dilated pupils. Okay, now, class, that's why the patient is asymptomatic until it ruptures. And then before the rupture, you would have the prodromal symptoms that, as I have mentioned. Then the patient would feel a sudden explosive headache. They would say that this is the headache that they felt for the first time. Then suddenly they would have loss of consciousness, and then nausea and vomiting. So class, if you would look at the sequence of the signs and symptoms, the sudden explosive headache is already an indication that the aneurysm has ruptured. Then that would lead to the loss of consciousness, because obviously there is already a decrease of blood flow of the blood going towards your brain tissues. Then there may be nausea and vomiting. Okay, stiff neck, class, and photophobia are indications of your meningeal irritation. Okay, these are indications of meningeal irritation. So meaning, class, the meninges is inflamed because of the cerebral blood that is coming out. Then you have your cranial nerve deficits, your stroke syndrome manifestations, and then you will have your pituitary malfunctions. Okay, so class, that's how the effect of your aneurysm would be. Okay, once, class, a major artery would rupture, the blood supply to the brain would be cut. Okay, and hence it would lead to tissue ischemia, later on, class, infarction. Now, there are several levels of severity according to rupture. Class, the first level, grade 1, okay, it's asymptomatic. Then there's minimal headache and then neck rigidity. Class, on grade 2, there is moderate to severe headache, neck rigidity, and then cranial nerve deficits are starting to occur already. On grade 4, the patient may be stuporous, and then the moderate to severe hemiparesis would already occur. And then your patient would start to manifest decerebrate. Whereas on grade 5, okay, we are exploring deep rupture of your aneurysm. So class, the severity of your rupture is often inferred from the manifestations of your subarachnoid hemorrhage. Okay, so class, I can say that a patient who is tuberous, who had a rupture of the AVM, okay, would have more needs medically compared to those who had a grade 3 ruptured aneurysm. Okay, so the higher the grade here, class, the higher the risk for your aneurysm. Then, so what are the major complications of aneurysm? Okay, class, aneurysm could be addressed by surgery. So, the surgery that could be done for aneurysm is that you could do clipping, then later on you would have it removed. But what are the major complications of your ruptured aneurysm first? Okay, it would result to rebleeding. Okay, so meaning there's a possibility that your patient will bleed again. And then there will be vasospasms. So when I say vasospasm, there is irregularity on the vasoconstriction and dilation of our blood vessels. Furthermore, we are exploring hydrocephalus. So class, hydrocephalus is related to the inflammatory processes. Okay, because of the inflammation, class, the tendency is for the fluid, okay, to shift from the outer part of the brain, which is your intravascular space, to the inner surface of your brain. So class, cerebral edema, and then later on, severe cases, hydrocephalus. Of course, because of the rupture, class, of your aneurysm, your hypothalamus will also be affected. Okay, and when I say hypothalamus, we are already considering a lot of organs and a lot of hormones that is produced by your hypothalamus. Then, we have your diagnostic test, CT scan. For example, class, in the hospital setting, I have encountered patients who were in, they would have aneurysm, and then they are advised by the physician to have the CT scan as frequent as possible. Okay, so for example, every 3 months or every 6 months, or if ever they experience a sudden change on the signs and symptoms. Plus, the aneurysm is usually allowed to mature before the physician will be addressing the problem. Okay, so sometimes, class, they do not just operate to clip the aneurysm, they are also considering the lifestyle. They are also considering the quality of life of the patient. Then you have your lumbar puncture, and then you can have your bilateral carotid and vertebral cerebral angiography. So class, the purpose of your carotid and vertebral cerebral angiography is for us to evaluate the patency of the blood vessels. Then we have your pharmacologic treatment. So class, you have your aminocaproic acid or your Amicar. You also have your calcium channel blockers. An example of your calcium channel blockers is your nimodipine. Then for your anticonvulsants, remember you have your phenytoin. The class, for the stool softener, a particular Philippine-based example could be your lactulose. Okay, you have your lactulose here, which is commonly used in the Philippine setting. Then you have your analgesics. Okay, of course, class, we are talking here about pain, so you need to give pain medications for your patient. Okay, so try to remember the functions of these medications. Now, let us talk about your aminocaproic acid. So class, your aminocaproic acid is in fact used to treat bleeding episodes in people with medical conditions such as your anemia, okay, or leukemia, or your, for example, class, if there are anomalies on the blood. Okay, so class, your aminocaproic acid could treat the bleeding episodes. Okay, could treat the bleeding episodes. So the common example is your Amicar, and then you also have your ipsicapron, okay, class, as part of the these classes of medication. Okay, so again, they're intended to treat the bleeding. Now let's proceed to surgery. Plus, of course, your surgery will be the mainstay treatment for your like arteriovenous malformation. Okay, so class, you have your craniotomy or craniectomy and repair of the aneurysm. So what's happening here in your endovascular balloon therapy? Okay, so class, a balloon will be inserted through the blood vessels of the patient. Okay, as you can see, class, on top here on the upper left side, you can see how the balloon would block. Okay, how the balloon, class, would block the aneurysm. And then for the surgery, you may opt to have your craniotomy or craniectomy. So class, when I say craniectomy, there will be a removal of a part of your, okay, a part of your skull is being removed. Okay, and the repair of aneurysm is done. So class, notice in the image that we are using your coils. So the purpose of these coils is to limit or to decrease the blood flow going towards that part of your aneurysm. Okay, you don't want blood to be going towards that part of your aneurysm. And then later on, class, clipping will be done. So the purpose of that is, of course, to reduce the blood flow going towards the aneurysm site and prevent rupture. Okay, class, although in some cases the operation may be delayed, but your aneurysm could not be addressed without us operating on it. Okay? Then you have your clipping of aneurysm. So class, when I say clipping of aneurysm, okay, you're basically clipping the aneurysm. The purpose of the clip class is to reduce the blood supply going towards that part of the body. And then with the hope that the aneurysm would become necrotic. Then we also have your endovascular balloon therapy, okay, with the use of your coils there. And then class, you have the following nursing diagnosis. So the nursing diagnosis could be altered cerebral tissue perfusion. It could also be anxiety, and it could also be body image disturbance. Now, a patient with arteriovenous malformation. This is a congenital intracranial lesion. Abnormality would occur usually in the embryonal development. And then the tangled collection of your dilated arteries and veins is what makes up your arteriovenous malformation. Okay, there is the arteries and veins are tangled, okay, with one another. Then blood would flow directly from the arterial into the venous system, hence bypassing the normal capillary network. Okay, so class, again, what happens if there is AVM? The blood class would flow directly from the arterial into the venous system. Okay, so instead class of having the capillary network wherein there will be an exchange class of your nutrients and oxygen, that's not happening in your arteriovenous malformation. Okay, so because of the malformation between the artery and the vein class, there is a bypassing of this capillary network. Hence, the exchange would not be taking place. So do you have the pathophysiology for your arteriovenous malformation? Okay, so class, for your arteriovenous malformation, you have the following. What happens is that there is shunting of the arterial blood directly into the venous system within the malformation. Because of this, there will be altered cerebral perfusion near the area of malformation. Also class, there will be tissue ischemia, okay, of the area surrounding the malformation. Later on class, you would have the problem of your vascular steal phenomenon. So what happens in vascular steal phenomenon? So try to look at my discussion on subclavian steal phenomenon. Then you also have class your progressive expansion of the blood vessels in and around the area. Okay, why is there having progression? Okay, the blood vessels would perceive that there is no energy supply, or the blood vessel would perceive that the body would need compensation. Okay, for that reason, class, okay, it would increase your expansion. It would result to expansion of your blood vessels in and around the area. In the long run, okay, rupture of the blood vessel is expected, and then displacement and compression of the brain tissues, okay, could possibly occur. Then later on, tissue ischemia and neuronal death of tissues. So basically, what we are talking here is a patient with an increased ICP due to the rupture of the arteriovenous malformation. Okay? So class, this is what happens in your arteriovenous malformation. Okay, earlier on our discussions on cardiac, okay, or I mean cerebral problems, recall that class that if there are problems on the arteries, okay, it is usually not entangled. Okay, but in this case, we are solving a concern on AVM. Okay, so you don't need to, you need to educate. Okay, you need to educate your fellow nurses, and then as long as other students and citizens. Okay, that class, for your AVM, you are not allowing your patient to exert, okay, extra effort. Extra effort is not needed for this patient, because that may result to loss of consciousness, and later on class could possibly aggravate the condition of your patient. Okay, so what are the clinical manifestations of your AVM? If the AVM is too large, seizures are expected. There will be recurrent headaches that do not respond to treatment. Okay, hemiparesis or weakness may occur, and then class, the local signs such as the pupillary changes. Class, you'd also be hearing bruit, and then you have your Kernig's and Grudzinski sign. So class, your Kernig's and Grudzinski sign, are for evaluation of the presence of meningitis or meningeal irritation. Okay, so these are the possible clinical manifestations for the patient. So class, this is how you test for your Kernig sign and then your Brudzinski sign. Okay, so once there is pain, class, that could not be tolerated by the patient, okay, you need to continue to perform your passive range of motion exercise. Okay, so diagnostic tests, we are still into CT scan, MRI, and angiography. Okay, between the three, it is your angiography class. Okay, that would have more detailed imaging of the blood vessels. So your CT scan and MRI would just be an augment, okay, to that of your angiography. We would really want to know on what specific area of the brain is affected. Then class treatment, of course, the malformation would be excised, okay, and then it could be done by embolization for large malformations. Okay, so class, what do I mean by embolization for large malformations? So class, the large malformation, class, when I say embolization of a large malformation, what they will be doing is that they will be administering emboli directly to the site of concern. And then class, the purpose of this is to ensure that there will be no adequate supply going towards that part of the body, so that the contralateral circulation would hopefully find means for it to be neutralized. So class, when I say embolization, earlier we're talking about pulmonary embolism that we would want to avoid. Okay, but in the nature of work, okay, class, you might have embolization for large malformations. And this is brought about, of course, by this could be also brought about by the advancement in medicine, but I have not encountered yet a case who had an embolization of the large malformations of the brain. Then you have your radiation or laser therapy for inaccessible AVMs. So you may have arteriovenous malformation, okay, which may be deep-seated already. So class, radiation or laser therapy may be done, okay, because it is these two that could possibly help your patient perform their task. So class, this is your embolization of an AVM with PVA. Yeah, your PVA is polyvinyl alcohol. Okay, maybe we can. Okay, so class, your embolization of your AVM is done using your PVA. So take note that your PVA is polyvinyl alcohol. Okay, that will be the end of our discussion for the disruptions in neurologic functioning for this midterm. I would like to make this opportunity to do an amendment or an erratum to the previous recording on endorphins and enkephalins and on the cerebral perfusion pressure. Class, to clarify further, your endorphins and enkephalins are considered to be inhibitory neurotransmitters. So your endorphins and enkephalins would belong to the category of the neurotransmitters referred to as peptides. They have low concentration in the central nervous system, but they are known to be very potent. And once again, their classification is inhibitory. Earlier, I have mentioned that your endorphins are considered to be our happy hormones that stand still. However, class, your endorphin, okay, your endorphin is inhibitory in such a way that it inhibits pain perception. Okay, it is involved in pain reduction and pleasure. In fact, the term endorphins is short for endogenous morphine. Okay, because structurally, your endorphin is about to be similar to the structure of your opioids, such as your morphine. And this works by reduction of your pain and pleasure. Hence, class, to clarify, endorphins and enkephalins are considered to be inhibitory. Thank you for the clarification raised on that. Now, on the cerebral perfusion pressure, this is to clarify the normal values of your cerebral perfusion pressure. I would like to elaborate again that your cerebral perfusion pressure is computed by using the mean arterial pressure minus the ICP, okay, or the intracranial pressure. Now, the normal CPP is 70 to 100 mmHg. Okay, earlier I could have mentioned that the normal value is playing between 70 to 160, so I would like to be clarified that the normal CPP as per our textbook is 70 to 100 millimeter mercury. Now, your normal ICP is 0 to 15 millimeter mercury. In fact, your textbook would say that the normal is 0 to 10, but the upper limit is 15 millimeter mercury. The normal mean arterial pressure is at least 65 millimeter mercury. And the goal of MAP is 110 to 130 millimeter mercury in the management of stroke. Okay? Now, let us be reminded that once the intracranial pressure rises, the autoregulatory mechanisms of our brain would be overwhelmed. The CPP could possibly be increased greater than 100 or decreased to less than 50. However, if the CPP of your patient is be less than 50, okay, neurologic damage, irreversible neurologic damage would start to occur. Hence, in our stroke management, the CPP must be maintained between 70 to 80. Okay, you might be wondering why, despite the normal value of the MAP to be 65, why is our goal 110 over 130? That is to ensure adequate CPP. Because recall, if your mean arterial pressure and your ICP, okay, will be equal to one another, the brain perfusion would stop. Okay, try to picture this. If the map is 100 and then the ICP is also 100, 100 minus 100 is obviously 0. So your cerebral perfusion pressure is 0. Okay, so our goal is we don't want our map to rapidly decrease, because once your ICP is equal to your map, cerebral circulation would cease. Hence, our goal is that the map will be maintained between 110 to 130, especially in the acute management of our stroke. Okay, now for the blood pressure, why the goal of 110 to 130 still? We only treat if the systolic blood pressure is greater than 220 or if the diastolic pressure is greater than 120 millimeter mercury, or if the MAP is greater than 130 millimeter mercury. If the systolic blood pressure, diastolic blood pressure is less than those values that I have mentioned, treatment or managing the blood pressure of the patient is not likely to happen. Okay, because we need the increased blood pressure of the patient to ensure that there will be adequate cerebral perfusion pressure. In other words, for our management in stroke to be effective, we need the MAP and the ICP to be decreasing at the same time also. Okay, we don't want the MAP to be decreased while the ICP is still increased, because that would mean that the cerebral perfusion pressure would not be working. Okay, I hope that this clarifies that the normal CPP is 70 to 100. Also, I would like to re-emphasize that your thrombolytic therapy is the management for ischemic stroke. Okay, your TPA is a thrombolytic therapy. Your TPA is the treatment of choice for your ischemic stroke. Your TPA, in order for it to be effective, the patient must fulfill the inclusion criteria. Without fulfilling the criteria for administration of TPA, the use of your TPA will be futile on the part of your patient. It will not be of help to your patient. Okay? Take note that the use of your TPA is the reason why we need an immediate CT scan for the patient. Okay, this is the reason why we need an immediate CT scan by the time the patient entered the emergency room. Okay, this is the reason why we have a window period of 20 minutes from the entrance to emergency room to the CT scan department if your patient is suspected to be a stroke patient. For us to consider or for us to confirm that this is ischemic stroke and not hemorrhagic stroke. Because your ischemic stroke is the one that could be helped, by your thrombolytic therapy, such as your TPA. Okay, your ischemic stroke again. Ischemic stroke could be helped by your thrombolytic therapy, such as your TPA. Your TPA, on the other hand, is contraindicated for your hemorrhagic stroke. It is contraindicated for your hemorrhagic stroke. Recall the term thrombolytic. Okay, it would lyse the thrombus. When the thrombus is lyse class, meaning it would destroy the clot, it would lead to bleeding. If I am giving thrombolytic therapy to somebody who has hemorrhagic stroke, you're bleeding your patient to death. Okay, kindly remember that. I would like to grab this opportunity to extend my thanks to Professor Roblesa for preparing the contents and materials of these presentations, and also to the team members, Professor Able and Mr. Cordero, for the effort shared. To the distinguished individual who have also extended her help on the design and layout of the presentations and who has shared unsurmountable gifts. You may be not able to listen to this part, but my heartfelt and hypothalamic-based thanks are yours. Congratulations, dear students, for reaching this far. Thank you for this opportunity to teach you. Thank you for the attention that you have shared. I would like also to thank you for the collaboration that you have extended. For your lectures, this is the best that I can give you this time. I am sorry if it may not be still enough, but I know that we have the opportunity to be better than who we are yesterday. Let's make use of that opportunity. I would like to remind you, I read this from a book, that there is a tiny gap between doing nothing and doing something, but the two options would have wildly different outcomes. I hope that you would do something, and I hope that you would do your best in your studies. If it suits you or if you feel comfortable, don't forget you can post your comments there, okay, just to share to your classmates some of your point of views and some of your inspirational quotes that you can extend to your classmates in this time that you are studying. And once again, always thankful for the attention that you have given. Thank you.